Welcome to this episode of Evidence of Greatness. For this episode, I'm going to review a recent article from 2023 that is a new meta-analysis about the effectiveness of solution-focused brief therapy. The interesting thing about this study is that it's looking at the effectiveness of solution-focused brief therapy specifically within community-based treatment centers. And I'll get a little bit more into that as we go. But one of the reasons that I considered this study is because so many of the people who are members of the SFU, the Solution Focused Universe, so many of the people who write and ask us questions, they specifically ask us about, does it work within certain populations? Does it work with people who have experienced lots of trauma? Those kinds of things. And this study helps to talk a little bit about that. So I just wanted to share this article with you so that you can kind of have an understanding of some of the most current research that's coming out about the effectiveness of solution-focused brief therapy. So what are community-based services? That's something that we need to start with. The authors of this study, they define community-based services as a practice settings within a geographical or catchment area that offers a network of nonprofit and public clinical and social services. They go on then to talk about what clinical services mean, and they refer to activities that are undertaken in a community that are not connected necessarily to institutional settings. But these clinical services agencies, they promote mental health. And then they go on to further define. So these are examples, things like children and family services agencies, community mental health clinics, probation offices, educational settings, these kinds of places where typically underserved populations would seek mental health services. So the research is going to look at people who are utilizing these types of services, and we're looking at, in essence, a variety of presenting problems or reasons that people might be to look for mental health services. So the next thing that we need to do is we need to look at, so as they were designing this study, what were they particularly looking at? Because this is a meta-analysis, they're basically taking a lot of previously designed studies, published articles, sometimes unpublished articles, and they're taking all of the results from these published articles and they're collating them together to say, across lots of studies, what do the findings of the entire group of studies tell us about solution-focused brief therapy's effectiveness? They were specifically looking at randomized controlled trials. So this basically is where people get solution-focused brief therapy in one group, and they're compared to other groups of people who do not get solution-focused brief therapy, but they get some other type of treatment. They then were also looking at studies that only had adolescents and or adults as the sample size. They considered children kind of a different group of people that they didn't want to necessarily confound with adolescents or adults. So they only looked at studies with adolescents and adults in them. And then also they looked at how effective the number and type of SFBT techniques were used. So I'll get a bit more into this as we get into the details as well, but they were looking at specific techniques like the miracle question, like exception questions, like relationship questions. And they were saying, does the number of techniques utilized within a certain therapeutic interaction, does that make a difference to the outcome? And then finally, they were looking at, does SFBT's impact on clinically relevant outcomes such as depression, anxiety, behavioral health and well-being, family functioning, and psychosocial outcomes? What impact did it have? So they were looking at 6 different outcomes and saying, does SFBT impact depression? Does SFBT impact anxiety? Does it impact behavioral health? Family functioning, right? So they were looking at, does it impact these six different types of outcomes? So that's specifically what they were looking at as they evaluated all of the existing literature that they could find. So then they had to say which articles are we going to include in the meta-analysis. And if you read the article, you'll see they did a broad search of all of the literature. They started with thousands of articles and they whittled it down to just the ones that met these criteria. So one of the things that was really important is that they had to name specific SFBT interventions by name. They had to focus on strengths. They had to use something like scalings or exception questions, coping questions, or other things that were listed in the SFBTA treatment manual. Again, the sample needed to be adolescents or adults, could not include children. Again, because the focus was community-based services, they were only looking at outpatient settings like hospital clinics, social services agencies, university clinics, mental health centers, community-based centers, not private practices, not big, large agencies, those kinds of things. Again, only randomized controlled trials, and then they were trying to match these specific outcomes that we mentioned before. So that's how they decided which articles should be included. And then the statistical analysis that they used, which may or may not mean much to some of you, but it was a robust variance estimation, or an RVE, and they were looking for Hedges G. And that basically, the G will tell us how big of an effect solution-focused brief therapy had. We're looking for a statistically significant effect. And then from there, they will also evaluate, did it have a little effect size, a medium effect size, or a big effect size? And so the Hedges G tells us how much of an impact it had. So that's kind of a little bit about the methodology. And then the results, they boiled it all down to include 28 different studies. Then they reported the demographics of those participants. Again, this is the total number of participants across those 28 studies. So about 68% of the participants were females. As far as race and ethnicity, 38%-ish were white, 19-ish% Asian, 11% Black, almost 3% Hispanic, and then 28% others. Other could include things like Alaskan or Hawaiian natives, Native Americans. Iranians were included specifically in that because there seemed to be a lot of research that was coming out of Iran. So that's how you can see the results break down as far as race and ethnicity. And then you can see all of the different kinds of community-based centers that the participants came from. About 21% came from community social services agencies, hospitals and clinics, mental health clinics, all of these places that we've talked about before. Now, when we look then at the results, what does this all mean? When we look at the RVE, it revealed that there was an overall statistically significant and medium treatment effect size across all domains. So what does that mean? That means that solution-focused brief therapy had a larger effect, or it had more significant outcomes than the comparison groups that they were looking at. And it wasn't just a little effect size, it was a medium effect. So it was a statistically significant difference, and the difference that it made was a pretty significant, substantial difference. Now, if we get into the nitty-gritty, basically what that means is when you look at standard deviations, you're going to say if it were one standard deviation away, then that was like a really big statistical difference. Solution-focused brief therapy on average had a 0.654 standard deviation difference, which means solution-focused brief therapy participants got better overall over participants who got other types of therapy. What other types of therapy? If you look at that bottom bullet, most of the time it was being compared to CBT or treatment as usual, which was usually an eclectic approach. Sometimes it was being compared to no treatment. So one group would get solution-focused brief therapy, and the other group would get no treatment until after the fact. So it didn't seem to matter if it was no treatment or if it was compared to CBT or other approaches. Solution-focused brief therapy did better in community-based institutions. In addition to that, then they looked at those, remember those 6 different things that they were, groups that they were looking for, and there was a statistically different medium treatment effect again for 4 out of those 6: depression, behavioral health, which does include things like trauma, domestic violence, those kinds of things, family functioning, and psychosocial adjustment. So again, 4 of the 6 had a significantly better impact from solution-focused brief therapy than others. There were 2 factors, you can see those at the bottom, that did not have a statistically significant difference, which was health and well-being. Now, what's important to note about that is that it doesn't mean that solution-focused brief therapy didn't work for health and well-being or anxiety. What it does mean is that it worked about the same as the treatment it was being compared to. So in this case, again, CBT or an eclectic modality. So in essence, solution-focused brief therapy was effective, but it wasn't more effective than the treatment as usual. But on 4 of the 6 presenting problems, solution-focused brief therapy was more effective. And that's a really significant finding, because in essence, what that means is that when people say, is solution-focused brief therapy evidence-based, this is one study that you could cite and say, yes, it is evidence-based. When it's compared to CBT, another evidence-based approach, it is at least as effective as CBT. But in lots of cases, it's actually more effective than CBT. And again, this is based on 28 studies from across the globe with a wide variety of participants. So there are some really significant things here. And it's not just a slightly bigger difference. It's a medium effect size, which is quite robust. Then we look, now this slide in essence is about, does it matter how many different solution-focused techniques get used? This big table that takes most of the slide is a table that came directly from the article. And they basically broke down all these bullet points are the different techniques. And they kind of clumped them together into 3 big categories. So they had an umbrella category of cooperative language or relationship questions. In essence, the client and the therapist working together. And under that big umbrella, they said these are things like co-construction talk, solution building talk, amplifying questions, difference questions, developing a collaborative relationship. So they were looking at those 5 variables and said, we're going to clump those together as linguistic or relationship questions. The middle column is client strengths or resources. And they then listed all of these interventions or techniques that fit under that. Things like focusing on strengths or resources, building the competency of the client, increasing positive emotion, exception questions, all of these things. And then the final category was future-focused questions. And you can see here, future focus, question, miracle question, goal-setting questions, end of homework, homework tasks, scaling questions. So they put them there and they said, in essence, does it matter which of these 3 types of techniques you use, or does it matter in general how many techniques you use? And one of the things that they discovered is that here on the right side, you'll see there was a statistically significant treatment effect when clinicians used 4 or 5 techniques, or when they used 6 to 9. So basically 4 to 9 techniques in a given session or across the course of treatment. That seemed to be really effective, and really effective compared to more or less than that. So that means that if I only used 1 or 2 of these techniques, and these are the specific techniques with the bullets, not the big techniques at the top. When I only use 1 or 2 of these, it doesn't seem to make much of a difference. So there's kind of a threshold of solution-focused techniques that I need to get over. But in addition to that, if you used more than 9, 10 or more, it seemed to also have diminishing returns. There was less effectiveness. And one of the things that the authors kind of conjectured about that is that this might turn out to just look like I'm throwing technique after technique after technique at people and not really listening to them and building a really coherent relationship with them. but instead it might sound really robotic. It might sound very just technique driven. And so there's kind of a sweet spot of do enough of these, but don't do too much. And then that big bold thing at the bottom, that's referring to the 3 categories as a whole. And it said the studies that used all 3 categories or interventions from all 3 categories, they reported an overall statistically significant and large treatment effect. Now, this is huge. What this means is we need to have all 3 of these big, broad categories contained in our solution-focused work. If people only used 2 or 1 of the big categories, it tended to not have a significant effect. But when I put all 3 of these together, what that does is that it makes the statistical difference really, really big. Now, I know this is a bit biased, what I'm going to say right now, but I'm just going to say it because this is really something that I think is a takeaway from this. When you think about the solution-focused diamond, in essence, these big things map so closely to the diamond, right? We're specifically focusing on language. We're specifically talking about the stance that the therapist needs to take, developing this collaborative relationship. We're specifically saying you get a desired outcome right at the beginning. And when you do that, then you can do resource talk, you can do future of the outcome talk, and you can do history of the outcome, which isn't really on here, which I think is an oversight. But in essence, you think about, we've boiled it down to 4 things and a closing. And we've stripped away a lot of these other things like homework and scales and formula for session tasks and all of these things. And that might, in essence, keep us within that sweet spot of 4 to 9 techniques, while also hitting all 3 of these major umbrellas. And so one of the things that I would say, and again, this is my own thoughts, my own commentary, not from the article, but the solution-focused diamond actually captures a really effective way to do the most important solution-focused things to get the largest effect without under or overdoing the techniques. So this, I think, is a huge, really important thing to be thinking about, is we as solution-focused brief therapists need to be well-versed, and we need to be able to be flexible to utilize whichever ones of these we need to, without overdoing our solution-focused work. And the stance of the solution-focused diamond really comes into play here, because it really emphasizes that entire first column. So I think this is a huge takeaway for solution-focused practitioners. And that kind of wraps it up. Here's the official reference for the article. In case you need that. But I just want to end by saying this is a really important article because it's brand new. It's from 2023. It really highlights what we need to do as solution-focused brief therapists. It reinforces the value of the diamond, and it shows that solution-focused brief therapy is an effective evidence-based approach, and even often more significantly helpful than other evidence-based approaches. So this is not a very long article, but it is packed with really valuable takeaways and important things that we need to attend to as solution-focused practitioners. So I hope that was helpful. Please let me know what thoughts and questions you have. But until next time, go do really, really great solution-focused work.